Hello, and thank you for joining us for today's webinar, Optimizing Your Revenue Cycle, How to Maximize Patient Payments and Minimize the Cost to Collect. I'm Adam Rubenfire, a content manager here at Phreesia, and I'll be introducing today's presentation. Today, we'll discuss how to assess and improve your return on investment in the payment process. Before we get started, I would like to quickly share some housekeeping notes. Attendees can submit questions at any time using the Q&A widget on the top left-hand corner of your screen, and I'll ask as many questions as time allows. In the resource widget on the left-hand side of your screen, you'll find two one-pagers, one offering an overview of Phreesia's revenue cycle management tools, and another about how Phreesia helps healthcare organizations increase revenue. Plus, we're sharing a case study about how a gastroenterology practice increased collections using our platform. Now, if you have technical difficulties, which we hope you don't, please click on the Help widget. It has a question mark icon and covers common issues. Since it's always one of the most frequently asked questions, this session is being recorded and you'll receive a link by the end of the week. Finally, a few brief words about Phreesia. Phreesia is guided by our mission of creating a better, more engaging healthcare experience for patients, providers, and staff. At over 120 million patient visits annually, over 1 in 10 visits across the US, our digital platform helps healthcare organizations enhance the patient experience, drive efficiency, and improve healthcare outcomes. We have real-time integrations with all the leading EHRs and registration, scheduling, and billing systems. We're a publicly traded company on the New York Stock Exchange, and we've been rated #1 in patient intake management by the research and insights firm KLAS 4 years in a row. Our security and privacy efforts are recognized with the industry's top certifications. If at any point during this webinar you have questions about what we're discussing today, or you're interested in learning more about how we help healthcare organizations improve collections and increase revenue, you can request a consultation using the drop-down on the right-hand side of your screen or visit phreesia.com. And I'm honored to introduce our speaker, who we're so fortunate to have with us today. Dr. Elizabeth Woodcock is the founder and principal of Woodcock and Associates. She is widely considered an industry leader in practice management, having focused on medical practice operations and revenue cycle management for more than 30 years. And with that, I'll turn it over to Dr. Elizabeth Woodcock. Dr. Woodcock, the floor is yours, and thank you for being with us here today.
Thank you so much, Adam. And I want to say thanks to Phreesia for sponsoring our webinar today. I'm really excited. And I actually think about the beginning of my career that was very, very long ago, 30 years ago, where we didn't really think about patient payments or the cost to collect. I remember we had about 200 FTEs in our business office, and 2 were dedicated to patient collections, and all they did all day long was write things off. Those were the days where we didn't realize it, but healthcare was fairly easy. And my, oh my, how things have changed. And what I want to do is really spend some time talking about, hopefully, kind of some more nuanced focus on the revenue cycle perspective from an investment idea, because we really, really need to take a pause today in the revenue cycle. It's gotten very, very complex to really think about what it cost us to run it. So hopefully this will be new information for y'all in our audience. And if maybe it won't solve any problems, but it will most certainly get you to think a little bit. That's my goal. Our agenda today is to be able to talk about the trends in revenue cycle management. So there are some things that are happening literally as we speak, these key elements related to the revenue cycle that are really, really making it a challenge to collect from patients and to minimize that cost to collect. So let's figure out what those are. And then we want to lean into this idea of cost of collection. I'm going to share with you kind of the traditional way that we've thought about our cost to collect. And then I'm going to share with you this kind of strange thing, a 2x2, and hopefully convince you that this is the 2023 way to look at, indeed, optimizing our cost of collections. And then we'll have a conclusion. Adam will rejoin us for our question and answer period. So lots and lots of challenges, not surprising for us. But I think it's important to kind of lift our heads up out of the business office. All of you are incredibly, very, very busy executives in the revenue cycle space. So like lifting our head up and realizing what's going around us, I think is really, really important. And, not surprising, the data is showing us that the cost of insurance that is being borne by Americans is not only expensive, but it really, really is rising higher and faster than the inflation rate. And that's putting a lot of pressure on our patients. We're seeing significant increases in cost sharing, whether it be on the primary care side. I mean, I remember when a copayment was $10 across the board, and honestly, we didn't really care, right? It was $10, $3, who cared? But now when you look at a $50 copayment, for example, for a rheumatology practice, like I don't know what y'all get in terms of reimbursement from your state Medicaid plan for a 99211, but I bet it's not $50. Like it is becoming close to the allowable, at least for a low level established patient visit code. I mean, cost sharing is a really important aspect of the revenue cycle. And especially post COVID, Americans are simply not able to afford it. When I started off in the revenue cycle, bad debt was really synonymous with patients who were considered indigent or fully charity care. And what's interesting is this data point on the bottom here, which is looking at bad debt that is attributable to self-pay after insurance. Patient financial responsibility after insurance is the leading element of a leading contributor to our bad debt. So all the more important reason for us to really lean into some of the prevention tactics that we'll talk about in a few minutes related to patient payments. Now, of course, not only do we have this going on in the commercial market, but lo and behold, we have a sea change going on in Medicaid. As you well know, Medicaid really represents 50 different insurance companies for all 50 states. And every state has been dealing with Medicaid for the history of Medicaid, now for the last, 50 years, a little bit differently. But during COVID, the federal government swooped in and said, in the Families First Coronavirus Response Act, states, you basically have to hold on to your beneficiaries. You have to keep them in Medicaid. Don't let them go. We need to have you keep their coverage during the public health emergency. And that's how the federal government was able to actually tell the states what to do. Because otherwise, right, I'm giving you an example. I'm based in Atlanta, so I'm in the state of Georgia. Georgia would have said, no, we don't want to do it. But during the public health emergency, the federal government had the right to be able to hold Georgia accountable for keeping all of its roster of Medicaid beneficiaries whole. And so y'all know the news, right? May 11th, 2023, just a few weeks ago, the public health emergency is over. And so what does that mean? Well, there's lots of implications related to telemedicine, et cetera, et cetera. But from a revenue cycle perspective, the big hit for us is that every state basically can unwind its roster of beneficiaries that had been holding as covered patients all during COVID. So what does that mean? That means that 5 to 14 million people across the country, some estimates are even higher, will lose their Medicaid coverage. And this, of course, will mean that those patients, I don't know what the data would show us, but I would guess it's probably 90 to 95% will go to self-pay. Will go to self-pay. So this is a really, really big change for us from a revenue cycle perspective. And all the while, the other thing that COVID has done is I would argue that it's given our commercial insurance companies a lot of money in premiums, right? Because for an entire almost year, we weren't even allowed to go out of our houses. Most of us didn't get routine health care, maybe even health care from a sick perspective, right? And so we're seeing unprecedented demand in the healthcare system in 2023. Unprecedented demand. Our lag times, our wait times are just crazy, crazy, crazy. So when you think about what happened then during COVID, is none of us got a phone call from United, Cigna, Blue Cross Blue Shield, Aetna, et cetera, that said, hey, Elizabeth, I know you haven't been to the doctor in the past year because you couldn't go outside because of COVID. You know what? Don't worry about paying me the next few months premium. I don't know about y'all, but I didn't get that phone call. I bet you didn't either. And so what's happened then is the insurance companies have really been able to gather a lot of dollars in terms of premiums and haven't had to pay out as much until all of this demand is hitting us in the last 6 months. I mean, practice after practice, hospital after hospital, dealing again with unprecedented demand. So what we've seen in the last 6 months, and I'm giving you my opinion in terms of the cause, but that's probably one of a multitude of factors. What is absolutely proven by data, by evidence, is that denials have gone up. And I mean, look at this, 15% now this is both on the hospital and pro fee side, but 15% of all commercial claims are initially denied. I don't know about y'all, but that's crazy. 15%. Can you imagine the people that have to deal with that have to work those denials in order to get their physicians and hospitals paid? And speaking of people, because they report to y'all, we don't have them. We have seen staffing go up. I mean, we've seen a big shift in terms of resources onto our clinical teams for a lot of different reasons, some state laws, some just trying to contend with this bolus of demand. And us back in the revenue cycle and the billing office, I mean, we're dealing with vacancies at unprecedented levels. We continue to struggle with staffing levels. And I think that the evidence is just now coming out about the complexity of healthcare that many of what I like to call our legacy healthcare systems are dealing with. So patients are going to Google, right? They're going to ChatGPT and saying, what's wrong with me? So our first visit as patients, now not obviously, for having a heart attack, but we've got a skin condition, our kid has a fever, right? I don't know about y'all, but I just go online, say, okay, well, what are the symptoms? Or I might, call a telemedicine company. My insurance company offers free telemedicine, so I might use that. I might go to ChatGPT and put in all my symptoms. My point is that the front door to healthcare is changing. And what that is doing is driving up the complexity of services that we and the legacy healthcare systems are handling. And that's changing the nature of the revenue cycle. Our claims are becoming more and more complex. It is harder to get paid. Wow. There's a lot of changes that, maybe, again, I don't have the answers, but maybe this offers some relief to you to say, well, my God, I wasn't going crazy because I've been doing this for a lot of years and this feels really different in 2023. And you're right. There is so many new pressures that we're seeing from a revenue cycle management perspective. We've got to rethink our processes. And I think part of this is recognizing how important the role we play into the overall patient's experience. And that's important for us to consider because we are no longer a back office function. So what we want to do is really try to think about this cost of collections. And I think it kind of plays into some of the trends that we're talking about, because it does make us pause and really think about what should we invest in the revenue cycle. So we really have two ways of measuring this. The traditional measure, which is where we collect all of the data about the cost to collect, and we present it on a dollar figure or as a percent of collections. And then what I want to introduce is this idea of a 2x2 matrix to try to give you a little bit more insight, really a useful decision tool. So let's dig in. Now, of course, the reason we evaluate costs, regardless of whether we're talking about like the cost of our imaging services within our multi-specialty practice, or maybe we're looking at, we have a very large FQHC, federally qualified health center, and we're looking at the cost of our dental services, right? So we can kind of think about service lines within a healthcare organization. And it's very common for us to say, like, is this a service that we want to offer, right? We want to invest in. Sometimes it makes money, sometimes it doesn't. But it's important for us, I think, always to be at least conversant with what it cost us to deliver. So we're going to focus in then on the revenue cycle, identifying the cost to collect. The evaluation of cost, I think a great way to look at this is we want to look at this by history. So we want to say, what was my cost this year? And let's compare it to last year or maybe the year before last for my own organization. And one could argue that an even better evaluation of cost is I don't want to just compare me to me, but I want to compare me to other like organizations. Now, y'all, I'm the first one to say, getting apples to apples when we do comparisons is very, very difficult in healthcare, and particularly in the revenue cycle. And in fact, we'll explore that a little bit. But I at least want to get in the same fruit basket, right? Because comparing my cost with my colleagues, with my peers across the industry, doesn't give me the answer, right? But just like this webinar, the reason I hope you're spending the time, like, you're investing your precious time in this, is we want to think, right? We want to really be intentional about how we run our businesses. So let's dig into it. Let's figure out all the costs that are dedicated or directly attributable to our business office. So we can take a look, for example, at our personnel. And I just ran this. This is a sample practice that I actually worked with. And so I just gathered up all of the personnel associated with the business office. So about 20 FTEs. And I pulled all their compensation. And these are very distinct business office employees, right? These are my AR reps. This is my refund coordinator. This is my denial manager, right? This is very distinctly related to billing. And I used, and I mean, you can refine this if you want to, but I use, you can see at the bottom here, 27% in terms of benefits, because we don't just have an hourly wage. You got to make sure if you're doing the true cost to collect, you also want to load it with the benefits. And then very importantly, because we have so many unfilled positions, I actually looked at budgeted, not necessarily filled, because I wanted to get my true cost to collect. And then I also pulled, for this healthcare organization, the supplies and equipment that they had that were directly attributable to the business office, all of my bank and collection fees. So like my credit card fees when I was processing credit card payments, for example, all my training and continuing education, my printing and postage, the rent that I was paying for the space dedicated to my business office, and the directly attributable coding and software. So this included, for example, the charge editing software that I used for the team. And then obviously you can count some others. So all told, almost always personnel is the majority of your expenses, but for this organization, it's about $1.7 million. Now, this is on an annual basis. An annual basis. You don't have to do that, but I find that to be the cleanest way to take a look at data. And again, it is distinctly costs that are distinctly related to billing. This is where it gets kind of messy, kind of murky, if you will, because you and I could be sitting there talking, and you're like, Elizabeth, I mean, we do have someone who does credentialing, for example. And you're like, well, I mean, that's pretty critical to the revenue cycle. But I know it's important for other things, right? Because they're doing our medical staff privileges for the hospital. But like, I'm going to take the FTEs, the equivalent, as close as I can estimate it, of my team related to prior authorizations, to credentialing, to coding, because my coders work my coding related denials. So I'm going to pull all of the data related to the FTEs that are aligned with the business office. And then I'm also going to take my computer, right? Because I mean, it's not like I would take away my computer system. If I didn't have a business office, I would probably still be paying for it. But I can argue that $147,000 per year, right? I actually do believe is attributable to my business office. Same thing for the phones, right? Because the phones I have those as part of my customer service patient collections team, and then a little bit other. So in addition to the 1.7 million, I have another 358,000 that is shared with another part of my organization, but is part of the revenue cycle. I can cleanly see that it's part of the revenue cycle. So I'm looking at a little over $2 million. That is my cost to collect, my cost of billing, my revenue cycle cost. So you look at that number and you're like, yeah, I don't know. So what? Is it good or bad? Right. And this is where, like, you can't stop here, because if you just show this to your doctors, we spend $2 million, they're going to freak out. They're going to freak out and they're going to say, how many proposals can you get from me tomorrow about outsourcing this sucker? $2 million? Are you kidding me? So you need to step back and you need to say, okay, well, this is what we spent last year. Maybe we spent 2.1 million last year. And they're like, oh, okay, we actually did better, right? So you need some kind of context. And in my opinion, the best context that we can get pretty readily is our revenue, right? So our revenue for this practice is $30 million and some change, almost 31 million. And so what we can do then with that data is say, okay, so we're spending 1.7 in directly attributable expenses from my cost to collect, another 360 that are shared, that are dedicated, on a revenue of 30.9 million. So for my quote unquote cost to collect, right, as a percent of my revenue, I'm spending 6.7%. 5.5 of that is just absolutely dedicated, directly attributable. And the reason I do that is because I find if you are evaluating outsourcing, then you're really only going to give up, if you outsource the whole kit and caboodle, the 1.7 million, right? You're not going to get rid of the medical staff credentialer. You're not going to get rid of your prior authorization team. Maybe you will, but you're probably going to have to spend some money to get those extra revenue cycle services. And so we're really trying to get as close to apples and apples to start using this data as a decision-making tool. So again, 6.7%. I don't know. Is it good? Is it bad? I don't really know. So what we want to do is kind of look at some industry data. And I usually don't use myself as a source, but I did a fair amount of research on the cost to collect based on specialty. And so I wanted to share this data with you. It is in the physician billing process, a book that I authored that is published by the MGMA. If you're interested in it, certainly feel free to shoot me an email. But it shows you the cost to collect, and it is a range. And you can see there's a fairly big caveat because it really depends on a lot of different factors. If I am in, for example, a market where I have a really, really heavy managed care mix, particularly Medicaid managed care, I'm in a state where workers' comp is a hot mess, like it is going to cost me more to get every dollar of revenue. And so there is, I mean, if anybody tells you otherwise, you should not work with that company because there definitely is a range of the cost to collect based on the factors related to your specialty as well as your payer mix. I've also included another really interesting article that focuses on the cost to collect that has some great data in it that you might be interested in. Now, great information, right? Hopefully you can follow that table. You can look at what's going on historically with your own organization, but you can also use that industry data, or maybe you have access to some other industry data. Great. That's awesome. And you can share that with your physicians or your executives, and you can kind of see, like, am I spending too much or too little? Too little. And I say that because I often find that healthcare organizations don't spend enough. And so you're leaving tons of money on the table, right? And that's where the nuance is really important. So, what I wanted to do was just walk over a 2x2 matrix. Now, this is something that can be used in a lot of different ways. It's often called a 4-blocker, sometimes a quadrant, because you can see it has 4 different quadrants. But what we do is we cluster the data in an XY format and generally break it down into 4 boxes. And it's used in the public health space, like in epidemiology and biostatistics, et cetera, but it can also be used as a management tool. And so in this case, I want to use it as a decision support technique. And what we want to do is we want to actually look at the value and the investment into the revenue cycle. And so when I think about, for example, the billing office, I think about the fact that it's a pretty big investment, right? So it's in that, right? When you scoot to the right, you go from 0 to whatever your dollar is. You don't actually have to put dollars on this. This is more of a conceptual quadrant. And then we might have some services that that don't actually cost us as much and maybe even have higher value, right? So we want to kind of play with this. Now, you can use a 2x2, and I've actually given you a number of other examples in the appendix. You can use a 2x2 to look at availability versus impact. So I do a lot of work, for example, with metrics. So if I want to look at a denial rate, for example, I want to really try to find where I can find a metric that is readily available, right? I can pull it out of my system and it has super high impact. So denial rate is one of those. I can get the data, and indeed, it can have a super high impact by sharing that with stakeholders. Another kind of 2x2 you could build is urgency versus importance. So, for example, I just talked to you about this whole Medicaid situation, right? This is probably literally happening at your organization today. So, this might be some sense of urgency. So, you could say, well, especially if I have a high Medicaid payer mix, Medicaid is a high part of my payer mix. I mean, this is really important for me to take a look at. So I need to start looking at the impact of this Medicaid change. And that might mean, am I looking at my Medicaid denials for registration related issues? And if I'm seeing those spike after May 2023, I got an opportunity. I got to lean into that. So I'm just giving you some examples of how powerful a 2x2 matrix can be as a decision support technique. And so as we start thinking about this whole idea of value versus investment, I like to start putting together then the quadrants so that I can start looking at, okay, where is my highest value at my lowest investment? Because, like, at the end of the day, that's kind of what we want, right? Our best return on investment is one that we've spent not so much money for, but we've gotten a really, really high value. And I don't know about y'all, but like just intuitively, I always put if I can automate, if I can use automation at a lower investment to be able to take what people are doing today. And people are amazing. People are wonderful. They're also very expensive. We just went over our revenue cycle analysis, our cost to collect. And I mean, without knowing your numbers, I can guarantee you that the number one thing you spend on in the revenue cycle is your team. And you need a team, right? But as you can see on the far right-hand quadrant, right, we spend a lot of money on our team. We spend receivables management, we spend refunds, we spend customer service. The reason I have denial prevention where we don't spend a lot of money is because we often use the teams that are already in existence. So my denial prevention is my coding team, my prior auth team, my awesome reception team, right? Because I want them to know how important accuracy is, what systems they use to make sure they get accurate data. And I add that to their responsibilities, but I don't have to create all these new jobs. And then, of course, automation. Great if I can get really, really high value at a low investment by replacing team members to be able to do that. So, what we really want to do then is kind of get even a little bit more nuanced, dive into receivables management. So, I want to just explain this. It's the same 2x2 where I have value and investment. So if I move to the right in my investment, right, that's where I'm spending more money. If I move up my value chain, I'm getting more and more value from it. So when I look at this 2x2 matrix, you can also see these bubbles. And what I've done is I've actually looked at different payers from a revenue cycle management perspective. So I'll just use United, for example. So my revenue cycles management team for United is actually, when I look at compared to Medicare, Blue Cross Blue Shield, and Medicaid, I spend a little bit less money on United Healthcare. This may not be for you, right? I'm just giving you an example so I can display this analysis. But it has pretty high value, right? It certainly has higher value than workers' comp and Medicaid, which are below it, okay? Because my collections are higher, my revenue is higher. So you can see United is a pretty big bubble. The size of the bubble is the gross charges associated with that payer. The investment is the personnel costs associated with that payer, and the value is the revenue. So what this is displaying for me is I spend a pretty high amount of money on, for example, Medicare, but I also get the most value from that. And that's pretty common because Medicare, for all the complaints that we have, is a pretty black and white payer, right? They're going to deny, you saw that chart from before, right? They deny it a third of what a commercial payer does, according to the evidence, according to the data. So what is on the bottom quadrant, though, in the orange bubble, is the patient. And it's a fairly high investment, right? We spend a lot of money trying to collect from patients, and it's a very low value because we don't get very much money for it. And so I love to do this 2x2 matrix because it allows me to sit down both with my own mind as well as with my team, to start saying, like, what is the value of each chair? So I might have Tony, for example, sitting in this chair, and I might have Shia sitting in the chair next to him, and I might have Juan sitting in the chair next to they, and I might have et cetera, et cetera. So I'm looking at my entire team and I'm trying to determine the right investment. So how much am I spending on each chair, and how much is the chair contributing back to me? And that can help us then make some decisions. If I'm spending a ton of money and my value is really low, then I really need to start thinking about, how can I make a more wise investment, right? That wise investment, I would often turn to automation as kind of my first, like, what could I do to stop spending a ton of money when it doesn't make sense to actually spend that money. And I mean, here's a good example, right? I can spend money. I love the United States. My little postal worker is amazing. I mean, he is simply amazing. Wonderful. And in fact, the evidence shows that most healthcare organizations on the provider side, they still use this lovely gentleman, the United States Postal Service. But in fact, when you look at the cost to collect per provider, my research shows it is about $8,000. And believe me, we ain't getting that $8,000 back. So we have to start thinking about, like, okay, if that chair, right? If that chair is costing us money, then it's even more compelling reason. I mean, we knew just intuitively that it's a good idea to kind of think about automation, et cetera. But now we actually have a roadmap where we realize, like, yep, it actually, compared to everybody else, like, we really need to think about an alternative. And I love to think about the fact, this image, right? We have two people's hands. Two people's hands. We have the United States Postal Service, which we're paying for in essence by the stamp that we put the onto the envelope when we send out statements, for example, to our patients. But we look at the other picture and we look at the hands and we realize those are our patients' hands. And I would argue they're a free employee and we need to use them. Now, speaking of employees, we also need to make sure that really our most important denial prevention happens on the front end of our healthcare organization. And it really is distressful for me to hear pretty ubiquitously that we call this team a piece of furniture. Right? When you think about it, you're hired for the front desk. You're going to work in the front desk. Here's my front desk. We even refer to the people as the front desk. This is not a good way to really lean into the revenue cycle today. In fact, these team members that we now call a piece of furniture are arguably our most important denial preventers. I like to call them the directors of denial prevention, as well as the directors of point of service collections, et cetera. So we also have to have the right people. But oftentimes, well, if you're going to sit in a seat and you're going to come to work, you're hired. That's not a good way to do this, right? We need to ask some very basic questions about, if we need that team member to be part of our revenue cycle, we should have some basic questions like, Mr. Walker's health plan has an allowance of $83.25. If he requires a 20% coinsurance, what should that be? How much does he owe? Use these questions or ones you make up as part of your candidacy review. Now, of course, you want to make sure you consult with a human resources attorney about doing any sort of pre-employment test. But this is a no-brainer. We need the right people to work in our organizations related to revenue cycle. And then, of course, we also need to sit back and say, like, we can do all the tweaks related to patient payments, related to the cost to collect. But if we're not delivering a good service, ain't going to do us no good, right? Because our patients are like, right, it took 8 months to get an appointment here. And you canceled it on me twice and told me I had to reschedule. I've already shown up once because nobody called. Like, we're a hot mess. We cannot then collect from effectively from those patients. So I hope this has given you a great framework for really thinking about leaning into the cost to collect. Really, though, this is everybody's job. I'm a little even hesitant to talk now about the revenue cycle because I still think it connotates that it's only one part of our healthcare organization. I think my biggest takeaway is yes, do the cost to collect, try to get a little bit more nuance with your decision making support tools. But at the end of the day, this is everyone's job. I'm super excited to be able to answer some questions. I'll go ahead and turn it back over to Adam for those questions. Adam?
Well, fantastic. Thank you so much, Dr. Woodcock. What an amazing presentation. I know we've got questions coming in. Audience, if you have questions, please keep sending them in. We'll get to as many as we have time for. And if we don't get to them, we'll make sure we follow up with you later. Dr. Woodcock, I would love to just address one of the things I thought that you shared that was interesting. You know, at a time when there are a lot of unfilled positions, it's not like we're replacing staff. We don't have the staff to do every job out there. I want to just understand, is what you're saying is that we can better allocate our staff to either like payers or projects and tasks that offer better revenue opportunity? Is that what you're suggesting here?
Yeah, and the reason I use the term value, Adam, is because I completely agree with you, but I also realize in healthcare that sometimes we don't make decisions just based on dollars. But my fear is that we make decisions based on what we used to do. In fact, I
Mhm.
think the biggest barrier to an efficient and effective operation, regardless of where we're talking about in the healthcare organization, is the old adage, well, that's the way we've always done it. And so I think by introducing some more nuanced decision making tools, by focusing on this investment value or using the matrix that I had presented in a different way, is honestly, it's to give us insight about ourselves and how we've made decisions in the past about where to invest. Because historically, we've done it because Gary told us to, or it was right for Juan, or, we've just not been really insightful and intuitive, especially in the business office. So I hope those tools are really exactly what you're talking about, which is where can we get the best value from our investment, but doing it in an intentional way.
Thank you. Yeah, I mean, one of the questions we're getting is that one of the reasons that it's expensive to collect is because the collections process is taking this practice a long time, that it's being drawn out. How can practice shorten the time it takes to get paid?
Some
What
of
are your
that
best practices?
Yeah, some of that I would argue is again how we do things. For
Mhm.
example, we send out statements every 30 days. Why do we send out statements? This could be transmitted electronically or by paper. It doesn't really matter. 30 days is like our cycle. And then when you ask people that, they go, that that's the way we've always done it. So again, every time we hear ourselves say that, it's, well, what's interesting is we actually get paid as Americans every 2 weeks. That's a typical payroll process. So why then should we send out statements every 30 days? So this is just one of many examples to think about reducing the payment cycle by questioning how we have done our how we've invested into our processes in the past. And of course, I love the idea of the free employee. And that, of course, is our patient. So, what can we do on a pre visit basis? What can we do before the patient even walks in the door? Using the computer, using the tablet, like, of course, some of your great products, so that we can really, really speed up that process.
Well, and it's not like we have to beg patients to do this. They'd much rather do it than dealing with the confusing paper bill or having to. I mean, I've called offices to pay bills, unfortunately, at organizations that don't use Phreesia, and I have to tell you, sometimes you can't get a hold of somebody, and it's your only option. So that's yeah. I think it's about giving people choice and flexibility and making it easier. Dr. Woodcock, we only have time for one more question. So I would just love to ask kind of like one sum up question to close us out. Audience, if we didn't get to your question again, we'll make sure we follow up with you. But I just want to think about Dr. Woodcock. What's the most significant drain on providers' billing resources today? And what do you think they can do to address it?
The most significant drain on providers' resources. Okay, unfortunately, I'm going to answer that in two parts. One, I think, is an external factor. I am extremely concerned about what's going on in the market, as I explained at the beginning, with regard to commercial payers, Medicaid, et cetera. So that is a factor that I would argue we can't really do a lot about. I think on the internal side, I'm going to go back to what I mentioned, the way we've always done it. I really do think we are our own barrier. And that might include, we've an employee who might be a little bit more low producing, which is why I love to do that kind of chairs analysis. I'm not talking about the people. I'm actually talking about the chair, the process, the payer, so that it gets it away from, I'm evaluating Natalie, for example, about how she processes workers' comp claims. No, I'm evaluating how we process workers' comp. I mean, just as an example, I was talking to an executive this morning and they were assigning two people to a work queue. And they were saying to me, well, one person can work a work queue from the top down and the other can work it from the bottom up. And I'm like, well, what happens if they meet? Well, they talk to each other. That's just inefficient. So it's asking ourselves, again, the way we've always done it, is that the right way? And then looking out into the industry, because if you find your cost to collect is higher, I mean, while that's not going to give you an answer, Adam, it would at least ask you to pause and think, how can we decrease those barriers and get paid faster?
Fascinating. Well, Dr. Woodcock, that is all the time we have for today. If you wouldn't mind flashing our thank you slide up there. I just want to sincerely thank you again, Dr. Woodcock, for such an engaging and informative presentation. I really enjoyed today. And if audience, again, if you have questions for Phreesia, for Dr. Woodcock, we can put you in touch. And again, if you have any questions for us, you want to see how Phreesia works, you want to learn more about us, you can request a consultation using the form on the right-hand side of your screen. Thank you so much again for joining us. Have a great day. Thank you so much, Dr. Woodcock.